3 days ago, a 30-year-old male presented to his physician with complaints of persistent fatigue that had progressively worsened over the past few weeks. He also reported experiencing symptoms of depression, including a marked lack of motivation, impaired concentration, and a pervasive sense of hopelessness. Despite these troubling symptoms, his medical history was notably unremarkable, with no chronic illnesses, recent infections, or significant stressors or trauma. To investigate, the physician ordered several laboratory tests, and the results were as follows. Urinary cortisol was low, serum cortisol was low, serum ACTH was low, and the electrolyte panel was normal. Upon reviewing these findings, it is imperative to consider the differential diagnosis. The concurrent presence of low urinary cortisol diminished serum cortisol and reduced serum ACTH levels, coupled with normal electrolyte levels, strongly supports a diagnosis of secondary adrenal insufficiency. Secondary adrenal insufficiency results from inadequate production of ACTH by the pituitary gland, which normally stimulates cortisol synthesis in the adrenal glands. This deficiency leads to decreased cortisol levels. Importantly, unlike primary adrenal insufficiency, secondary adrenal insufficiency typically spares aldosterone production, preserving normal electrolyte levels. Understanding the distinction between primary and secondary adrenal insufficiency is crucial. In primary adrenal insufficiency, or Addison's disease, the adrenal glands are directly affected. This results in deficiencies of both cortisol and aldosterone, often leading to electrolyte imbalances. In contrast, secondary adrenal insufficiency arises from issues in the pituitary or hypothalamus. Here, aldosterone levels usually remain normal. So, to confirm the diagnosis, further endocrine testing may be necessary. First, an ACTH stimulation test that measures the adrenal response to synthetic ACTH. Next, pituitary imaging, such as an MRI, can identify structural abnormalities in the pituitary gland that might explain ACTH deficiency. If ACTH stimulation results are inconclusive, an insulin-induced hypoglycemia test can evaluate the hypothalamic pituitary adrenal axis response. The CRH stimulation test helps differentiate between hypothalamic and pituitary causes of secondary adrenal insufficiency. Lastly, assessing other pituitary hormones checks for deficiencies, which might indicate a broader pituitary dysfunction known as hypopituitarism. Diagnosing this condition requires meticulous evaluation and clinical expertise. Patients undergo a comprehensive series of assessments, including detailed patient history, symptomatology, and laboratory investigations to pinpoint the underlying cause accurately.